Alright, this presentation is over scapular dyskinesis rehabilitation. If you haven't already looked at Carly's presentation on regular scapular dyskinesis, then I suggest you go watch that beforehand, because this won't make sense unless you do. So to start off with, just a little recap of what scapular dyskinesis is. It's kind of just a dysfunction of the shoulder around the scapula, clearly. So it involves some muscles, some being tight, some being extra loose, which puts the scapula in a position that is more vulnerable to injury and to not function properly in conjunction with the shoulder joint. So there's multiple causes. It can be secondary to a shoulder injury. It can be from muscle weakness, from muscle tightness, from spine problems like kyphosis and scoliosis, neurological injuries, or improper biomechanics. Scapular rehab is unique in that there's multiple ways to attack it, and it's not just a single injury like many other injuries we have already talked about. The basic principles when rehabbing the scapular dyskinesis is to work proximal to distal, stretch what is tight, strengthen what is loose, start with low weight and increase as the patient gains strength, and increase range of motion, which is rarely needed because with the scapula there's not much inhibition of the range of motion. The methods used when going after scapular dyskinesis rehab are assistance, which involves the gliding and the more Mulligan type rehab, stretching, muscle reeducation, muscle conditioning, and surgery if needed to correct underlying problems. To start off with the assistance, like I mentioned, it's more of the scapular gliding and Mulligan aspect. So the main one that we use is just when you're adducting the humerus, you glide the scapula into the proper range of motion. So when the shoulder raises, you raise the scapula, and it just aids in reducing pain in the area and teaches the scapula how to glide properly. When it comes to muscle reeducation, there's multiple ways you can go about it, but the basic principle is just getting the muscles to fire properly and rehabbing that mind-body connection. So one of the main ways that we do it in the later stages of rehab, once the muscles are fully activated and everything, is proprioceptive exercises, which include clap push-ups, up-down planks, anything to use the combination of eccentric and concentric going back and forth. You want to use slow resistance and low resistance movements to start, because you're trying to focus on the mind-body connection and not how much weight you can lift. The lower weights allow the body to focus on what's being moved and when it's being moved. Another thing that you can do at the beginning of rehab is electric stimulation, which can help the muscle fibers fire when you want them to fire. Moving on to the more typical rehab, the strength and stretching. There's 3 types, like Carly just probably mentioned in her video. The first type would be the first type of scapular dyskinesis would be the inferior angle prominence. So the priorities when you're having this are to strengthen the inferior deep muscles, which will act to pull the inferior angle towards the body and downward, and to stretch the superior muscles, which will release the tension, and the lever on the scapula that's pulling it up will be released, so it will slide back down. You want to strengthen the serratus anterior, which hopefully we all know where that is, but if we don't, it is on the underside of the scapula and attaches the scapula to the rib cage and acts to pull the scapula down and cinch it to the back. So when you're attacking this muscle, you would like to do anything that would extend the arm and also bring the scapula into the body. So laying punches, push-ups with a plus, serratus raises, which use a band and you put it on either side of your hand and just do flexion with both shoulders and keeping your back against the wall. And then plank punches, where you're in plank form and you punch straight out in front of your head. There's multiple other ones, but they basically all do the same thing with slight variations. You also want to strengthen your lower trapezius, and that would be done by doing Y's, W's, face pulls, arabolas, Superman. Again, there's variations of all those, but basically all include the same principle. When you're strengthening muscles, you just want to focus on which direction the muscle fibers run and then contract your body in that form. When it comes to stretching for type 1, you want to focus on the pec major and minor and the anterior deltoid, and releasing any tension in that area and hopefully lengthening the muscles. Type 2 dyskinesis is the medial and inferior border prominence. The priorities for this one are to strengthen the medial and deep muscles and stretch the lateral and superficial muscles. So you're trying to pull the medial border of the scapula closer towards the spine and closer to the ribs. This is the type where you get the term scapular winging, which has the medial border flying out. You want to stretch the lateral superficial muscles like stated so that you can release the tension on that side and allow the adducting muscles to pull the scapula farther in. So for this, you want to strengthen the serratus anterior and the lower trapezius, which we've already mentioned in previous slides, but you also want to strengthen the rhomboids, which will pull the scapula closer to the spine. To strengthen the rhomboids, you can target the exercises that involved pinching the shoulder blades back and doing any sort of movement that will straighten the back out. So prone lateral raises, prone rows, face pulls, and Superman are again excellent exercises for this, and variations of those you can encounter different variations. To stretch, you want to stretch the supraspinatus and infraspinatus muscles, which attach the scapula to the lateral structures of the body. And by stretching those, like stated earlier, you'll be able to move the contracting muscles more easily. For type 3 dyskinesis, which is the scapula raises superiorly, the priorities are to strengthen the inferior and stretch the superior. All this stuff is common sense, but the more you hear it, the more it's going to be ingrained. To strengthen, you want to focus on the serratus anterior again and the lower trapezius. Both those have been mentioned in previous slides, so we're not going to go over exercises for those now. You want to stretch the upper trapezius, the levator scapula, and the pectoralis major and minor. So anything that pulls the scapula up, you want to relax it so that the scapula goes back down. This type of dysfunction is typically categorized by skewed upper trap to lower trap strength ratio. So the upper trap is going to be a lot more strong than the lower trap, so you want to target the lower trap. So during any sort of rehab for scapular dyskinesis, you're going to take a slightly different approach than most injuries. So you're not going to want to limit any activities that the athletes are involved in unless it's causing pain. So the only thing that will be causing pain would be muscle injuries, which would be already addressed by this point, and bad mechanics. So once you address the bad mechanics, you can put them back into the regular motions that they would be typically doing for their sport and continue rehabbing that way. So just an example would be an overhead athlete, like a baseball player. If they have pain when throwing, you can work on the throwing mechanics, and if that makes the pain go away, then they're fine to continue throwing while you continue to rehab the rest of their scapular dyskinesis. This is a interesting rehab process because, like I said, you don't have to disrupt their normal activities very much, and that ultimately returns to a quicker return to play. To go along with the strength and stretching and the gliding and all the other stuff that has previously been mentioned, you can focus on different modalities to help loosen the muscles and get the muscles in a prime position to fire. So scraping and cupping and massage are 3 ways to do this. So they basically all work on breaking up fibrous adhesions in the muscles, but they do it so in different ways. Scraping, you compress it to break it up. Cupping, you pull it apart to break it up. And massage is a little bit of both. There's no one way that works better than the other. There's several contraindications to each one, but we can get into that another time. But yeah, they basically all do the same thing. It's really just a preference for the athlete and based on what has worked in the past. So after looking at all that, my PCOT analysis was about a study on the infraspinatus muscles of athletes, 31 volleyball players, I believe. Yes, 31 professional volleyball players, and they had their strength of the infraspinatus muscle tested by the infraspinatus strength test and the infraspinatus scapular retraction test. And then they went through a strength training program through physical therapy. And at the end of 6 months, they were able to successfully increase the strength of their infraspinatus and decrease any scapular dyskinesis involved. So that is it for my presentation. If you have any questions, please feel free to contact me. I'd be happy to talk more about any of these topics. All my works cited here have excellent sources that would be great for helping you understand the topic more.